Anxiety and eating disorders. Eating disorders. Preoccupation with body shape and weight is very common in many cultures. The desire to be slimmer has created a highly profitable diet industry in the Western world, selling nutritional advice, exercise regimes and appetite-reducing drugs. Up to 90% of women have been on a diet at some time in their lives. Ogden, 1992. The vast majority of dieters do not go on to develop the potentially dangerous relationship with food seen in eating disorders. However, it is perhaps not surprising that these disorders have primarily affected females. Doctors' descriptions of patients with eating disorders were made as far back as the 17th century, Morton, 1694. However, these disorders did not appear in the DSM until 1980. A more recent edition made a distinction between anorexia nervosa and bulimia nervosa. Symptoms and diagnosis of anorexia nervosa. Anorexia usually develops over a period of time, often, although not always, after dieting. The onset of symptoms can also follow a time of personal stress, such as being bullied at school. Sterling and Helliwell, 1999. The term anorexia nervosa means loss of appetite for nervous reasons. However, the term is misleading, as most sufferers do retain an appetite for food, which they rigorously attempt to control through starvation, overexercising, vomiting and the excessive use of laxatives. Physical symptoms. The physical symptoms of anorexia nervosa are extreme weight loss in adults, failure to gain adequate weight in relation to growth in children and teenagers, downy hair growth on the arms, back and face, poor circulation and feeling cold, dry, rough, discolored skin, low blood pressure, disrupted menstrual cycles for females and, eventually, loss of fertility, loss of bone mass and, eventually, osteoporosis, brittle bones. Psychological symptoms. The psychological symptoms of anorexia nervosa include intense fear of gaining weight, even within the normal weight range. The sufferer can be constantly anxious about putting weight on. There is a tendency to assess self-worth almost exclusively in terms of weight and shape. Distorted perception of body shape and weight. Individuals overestimate their own body shape, believing they are bigger than they really are. Denial of the problem. Sufferers refuse to acknowledge that they are underweight or not eating. Changes in personality, and mood swings. Individuals may feel depressed or irritable and often concentration levels are affected. Progress at school or work can deteriorate. Behavioral symptoms. The behavioral symptoms of anorexia nervosa include rituals attached to eating such as cutting food into tiny pieces. Food causes high levels of anxiety in the anorexic. Rituals are undertaken in an attempt to control anxiety in a similar way to obsessive-compulsive disorder. Restlessness and hyperactivity. Wearing baggy clothes to conceal weight loss. Vomiting. Taking laxatives or exercising excessively. Diagnosis. The following 4 diagnostic criteria indicate anorexia nervosa. 1. Refusal to maintain normal body weight. Typically the person weighs less than 85% of what is considered normal for their age and height. 2. Intense fear of gaining weight, which is not reduced by weight loss. Anorexics believe they can never be thin enough. 3. A distorted sense of their own body shape, believing certain parts of their body, usually stomach, bottom or thighs, are too fat. 4. For female patients, an absence of menstrual periods. Davison and Neal, 2001, state that anorexia nervosa usually begins in the early to late teens and is 10 times more frequent in women than in men. In the UK, the disorder affects up to 1% of adolescent girls, more often occurring in the higher socioeconomic groups. Sterling and Helliwell, 1999. However, a review undertaken by the Eating Disorders Association, 2000, identified that up to 10% of people with eating disorders are now male. The incidence of anorexia in men appears to be growing. Symptoms and diagnosis of bulimia nervosa. Bulimia nervosa involves rapid consumption of a large amount of food, a binge, followed by action to reduce the likelihood of weight gain, such as vomiting, a purge. Other non-purging behavior can also be seen, such as over-exercising or fasting. Physical symptoms. The physical symptoms of bulimia nervosa are frequent weight changes, sore throat, gum disease and tooth decay caused by excessive vomiting. Swollen salivary glands. Poor skin condition. Irregular menstrual periods. Irregularities in heartbeat. Psychological symptoms. The psychological symptoms of bulimia nervosa include uncontrollable urges to eat vast amounts of food, an obsession with food, which involves constant calorie checking, distorted perception of body weight and shape, mood swings, anxiety and depression, low self-esteem and guilt. Behavioral symptoms. The behavioral symptoms of bulimia nervosa include binging and vomiting, excessive use of laxatives, diuretics or enemas, excessive exercise, secrecy and a reluctance to socialize, shoplifting for food, food disappearing unexpectedly. Diagnosis. Bulimia tends to develop later than anorexia, typically in young adulthood. A substantial minority of sufferers will also abuse drugs and alcohol. Sterling and Helliwell, 1999. Again, bulimia affects mainly women, with men representing only 5% of reported cases. It tends to affect people in the higher socioeconomic groups. Bulimia is more common than anorexia, affecting about 3% of the population. For a diagnosis to be made, episodes of binging and purging should occur twice a week for 3 months. Societal explanations for eating disorders. This approach looks to cultural pressures as an explanation for eating disorders. Over the past 50 years, the ideal body shape for women has changed in Western society, with a steady progression towards increasing thinness. The societal explanation acknowledges the importance of social influences on an individual's psychology. Social learning theory states that people learn through observation and imitation of role models. In addition, positive reinforcement increases the likelihood of imitation. Many young women look to the media for information about what is desirable. If thinness appears to be highly valued, then the media is positively reinforcing a particular body size and shape. Study 1. The Aim. Ogden, 1992, looked for evidence that the ideal shape for women has become slimmer. Method. The physical features of female fashion models recruited by an agency in London from 1967 to 1987 were analyzed. The researchers examined the models' height, bust, waist and hip measurements. Result. Over the 20-year period, models became taller, with a decrease in hip and bust measurements relative to waist size. Conclusion. Ogden concluded that the ideal female shape had become more androgynous, could be either male or female, and that this has an effect on how women perceive their own body shape. Bemis, 1978, suggests that eating disorders arise from attempts by young women to conform to a stereotyped and unrealistic body shape shown in magazines, television, films and adverts. Anorexia and bulimia are much more common in Western societies where thinness is regarded as desirable. Western society's attitude towards fatness has also grown increasingly negative. De Jong and Kleck, 1986, found that obese people are seen as less smart, more lonely, and greedy for the affection of others. Study 2. The Aim. Furnham and Baguma, 1994, investigated cross-cultural differences in ideal body shape. Method. Ugandan and British college students were asked to rate the attractiveness of drawings of nudes ranging from very thin to very obese. Result. Ugandan students rated the obese females as more attractive than the British students did. Conclusion. British attitudes to obesity are more negative. This may contribute to the higher incidence of eating disorders in the United Kingdom. Evaluative comment. Social pressures appear to contribute to the onset of eating disorders. They are certainly more common amongst people who might be expected to be concerned about their appearance, such as dancers or models. Garner et al. 1980. As we are all subject to the same cultural pressures, eating disorders such as anorexia and bulimia should be more widespread. Instead, there is an increase in the number of overweight people, with 16% of women categorized as obese. Ogden, 1992. There must be other contributory factors, such as family background or biology. Family pressures. Minuchin et al. 1975, proposed that the family had an important role in the development of eating disorders. He used the term enmeshed family to describe the way family members relate to each other. Parents in these kinds of families tend to speak for the child, believing that they know exactly how the child feels. Minuchin thought this over-involvement and protectiveness promoted the development of eating disorders. During adolescence, when a young person is striving for autonomy, the parents tend not to acknowledge or encourage increased independence. As a consequence, the child tries to gain some sense of control by refusing to eat, or binging and purging. Minuchin gathered evidence for his theory by working with patients with eating disorders and their families. He developed a treatment method known as family therapy, claiming that recovery could only occur if the whole family was helped to communicate more effectively. Research has focused on the relationship dynamics within the family. Study 3. The Aim. Humphrey, 1989, investigated the way families with an anorexic daughter communicated. Method. He used the structural analysis of social behavior, SASB, which is a method used to analyze the interactions of families. Result. Parents' communication with anorexic daughters consisted of double messages. For example, they might offer verbal affection but at the same time dismiss the daughter's thoughts and feelings. The daughter would therefore be confused and swing between expressing herself and submitting to the parents' wishes. Conclusion. Interaction is unusual in families with anorexic children. Mixed messages caused confusion in the children, which may be why anorexia develops. Evaluative comment. One problem with research into family dynamics is that it happens after diagnosis of the eating disorder. The communication within the family may have changed because one member has become ill. It is therefore not possible to state causality. Woodside et al. 1995, found that family functioning improved after treatment of the patient. His study supports the idea that eating disorders cause family problems, rather than the other way round. Alternatively, Van den Brouwer et al. 1995, found that parents of children with eating disorders did not appear to be very different from a control group. In their observational study, both groups gave similar amounts of positive and negative messages to their children. Biological explanations. Both anorexia and bulimia run in families. Strober et al. 1990, found that first-degree relatives, parents, of anorexic daughters were 4 times more likely than average to have the disorder themselves. Researchers have again turned to twin studies to find evidence of a genetic link. For example, Holland, 1984, found a higher concordance rate for eating disorders in identical twins, 55%, than non-identical twins. This indicates that genetics are implicated in anorexia. However, the concordance rate is not 100% and therefore other factors must also be involved. Study 4. The Aim. Smith et al. 1999, wanted to investigate the role of serotonin in bulimia nervosa. Method. Patients who had recovered from bulimia nervosa had their serotonin levels reduced using a drug treatment. The researchers closely monitored any changes in mood and behavior. Result. Patients reported an increase in negative thoughts about their body as serotonin levels dropped. For example, they began to worry about feeling fat. Conclusion. Low levels of the neurotransmitter may be implicated in the onset of bulimia nervosa. Support for this theory also comes from an effective treatment for bulimia. Antidepressant drugs that increase serotonin can lead to dramatic reductions in the frequency of binge eating. Sterling and Helliwell, 1999. Evaluative comment. Research will continue into the role of biochemistry in eating disorders. However, the focus on hunger, eating and appetite fails to acknowledge other more psychological symptoms in eating disorders, such as intense fear of being fat, or behavioral symptoms such as ritualistic eating patterns. Disturbances in neurotransmitter function have also been found in mood disorders, see Chapter 3. Research is yet unable to explain why low serotonin levels in the brain lead to bulimia in some people and unipolar depression in others. It is likely that cultural influences may have an impact. Cognitive explanations. Cognitive theories emphasize the thought processes of a person with an eating disorder, in particular, over concern with the importance of body weight and shape. Beck et al. 1979, found that people who were having psychological difficulties in life often had unrealistic expectations about themselves. Garner and Bemis, 1982, have applied some of Beck's theory to eating disorders. Fairburn, in Horton et al. 1989, found that most patients with eating disorders admit they are unlikely ever to be completely satisfied with their shape and weight. If these patients continue to determine their self-worth through body shape, they are likely to continually suffer from eating disorders and remain unhappy. These distorted thought processes lead the patient to adopt strict, inflexible dietary rules. If the rules are broken, for example, by eating the wrong type of food, the sufferer will experience a sense of failure and a decrease in self-esteem. In an attempt to feel better, the patient embarks on an even more rigorous diet. Losing weight provides the patient with an objective measure of success. Study 5. The Aim. Zellner et al. 1989, investigated women's assessments of their own body size. Method. Female participants were given a questionnaire to assess whether they had a distorted attitude towards eating. Women with high scores or low scores were then assessed on their own body size, using line drawings of women with varying body weights. Participants were asked to pick the one closest to their own body shape and choose an ideal figure. Result. High scorers overestimated their own body size and chose a very thin figure as their ideal when compared with low scorers. Conclusion. Cognitive distortion in women with eating disorders includes an overassessment of their own size, as well as over-concern with body weight. Even when anorexics are reduced to skin and bones, they still claim to be too fat. Evaluative comment. While there is plenty of evidence to demonstrate cognitive distortion in those diagnosed with an eating disorder, the approach does not explain where these thoughts originated. Thompson et al. 1995 found that criticism from peers and parents about being overweight was positively correlated with disturbed body image. Some studies have indicated that reports of childhood physical or sexual abuse are higher than normal among patients with eating disorders. Deep et al. 1999. Other research has highlighted the role of stress such as exam pressure or relationship problems. The cognitive approach ignores these external, environmental causes. Treatments for eating disorders. There are currently several treatment methods available to help individuals with eating disorders, including weight restoration, behavior therapy, and cognitive treatments. Research into which is the most effective treatment is ongoing. Weight restoration. For some patients with anorexia, weight loss is so severe that they have to be admitted to hospital for treatment. If patients are underweight by 60% for their age, sex and height, and are refusing treatment, they can be admitted to hospital without their consent under the Mental Health Act. While under supervision on the ward, patients are slowly introduced to eating regular meals and snacks. Fairburn, in Horton et al. 1989. It usually takes about 2 weeks for patients to be able to physically cope with a normal quantity of food. A weekly weight gain target is set of around 1.5 kilograms. To achieve this weight gain, the patient must eat between 3,000 and 5,000 calories a day. This would require abnormally large or frequent meals, so high-calorie drinks and snacks are often given in addition to normal meals. Patients are usually weighed each day and monitored closely to ensure that food is not being hidden away or vomited. Patients are encouraged to talk to nursing staff throughout the treatment about their distress and resistance to weight gain. The doctors and nursing staff will negotiate with the patient to agree on a satisfactory target weight. Sometimes, this might be the weight they were before they became ill. However, for patients who have been ill for many years, it is often difficult to identify a natural weight. Generally, the target weight will be at least 90% of the average for the height, sex, and age of the patient. This should allow normal hormonal functioning to return and also represent a body size at which eating without dieting is possible. Once patients enter the target weight range, the high-calorie supplements are phased out. This type of inpatient weight restoration takes between 2 and 3 months to complete. Sometimes, the treatment will include a program of behavior therapy. The patient usually remains on the ward for between 2 and 4 weeks after reaching their target weight. The transition from inpatient to outpatient care must be very carefully managed to avoid relapse, and may involve some form of ongoing psychotherapy. Patients who are less dangerously underweight can take part in weight restoration programs as outpatients. Initial appointments at the hospital will be very frequent to get the weight gain started, for example, 3 times a week. Patients monitor their own food intake, but weight gain is monitored by hospital staff. The expected weight gain for outpatients is lower than for inpatients, at about 0.5 kilograms per week. During their appointments, patients are given help and advice about their diet. They are encouraged to eat regular meals, and in the initial stages they may need energy-rich supplements. Outpatient care may also involve some form of psychotherapy, usually cognitive. Evaluative comment. Weight restoration within hospital settings can be life-saving for dangerously underweight anorexics. Most of the physical complications of anorexia nervosa can be reversed if weight is restored. Unfortunately, Keeping the weight on after the patient is discharged is more problematic. Despite outpatient care, many patients relapse and require further hospital treatment. This may be because the treatment focuses mainly on the physical symptoms rather than the psychological causes of the disorder. Weight restoration concentrates solely on the individual patient and the problem is defined within the sufferer. Therapists such as Minuchin et al. 1975 argue that eating disorders are an interpersonal problem. They occur as a result of communication difficulties between family members. Treatment should therefore include the whole family rather than just the anorexic individual. Behavioral therapy. This type of treatment is often used within weight restoration programs. The belief is that patients can learn new and more adaptive ways of responding to food. More lenient approaches have used negative reinforcement. Tuis et al. 1984 recommended that staff and patients negotiate a weekly weight gain. Patients should be given full access to social contact and advised that if their weight doesn't increase after 4 days, they will be required to take bed rest for 3 days. During this time they will be more closely monitored and not allowed to exercise. Tuis argued that this approach helped the patient to develop a sense of control over their own treatment and was as effective as stricter programs. Behavior therapy is also used outside the hospital setting, in individual therapy sessions. Study 1. The AIM. HSU 199. 0. Reported on the use of a strict operant conditioning technique to treat patients with anorexia. Method. Patients were isolated as much as possible. Social contact was given when the patient ate a meal. Rewards, such as access to television, having visitors or going outside for a walk, were given when the patient gained weight. Result. The program was successful. Patients ate more regularly and gained weight. Conclusion. Operant conditioning treatments, using positive reinforcement for appropriate behavior, can help the weight restoration process. Evaluative comment. Behavior therapy regimes have advantages. They are easily understood by staff, family and patients, and are straightforward to carry out. However, critics of strict operant conditioning argue that it is degrading for patients to have their privileges taken away and difficult to maintain outside the hospital ward. Today, most therapists accept that as well as changing behavior, clients must also be helped to change the way they think. Cognitive behavioral therapy has proved effective, particularly for treating patients with bulimia nervosa. Cognitive treatments. Patients with either anorexia or bulimia nervosa have extreme concerns about shape and weight. Fairburn and Cooper, in Horton et al. 1989, highlight how these concerns mean patients begin to judge their self-worth almost exclusively in terms of their ability to control their food intake and weight. These overvalued ideas about thinness must be challenged if the patient is to make a full and lasting recovery. Thought modification is one of the major goals of cognitive treatments for eating disorders. Beck et al. 1979 called this process cognitive restructuring. Study 2. The AIM. Fairburn, 1985, applied cognitive restructuring techniques to the treatment of bulimia nervosa. Method. Patients were given individual cognitive treatments for about 5 months. There were 3 stages to the therapy. In stage 1, the cognitive explanation for bulimia was given to the patient. They were asked to fill in a food diary. This helped the therapist to see some of the patient's negative thoughts about themselves. The emphasis of stage 2 was on examining and replacing the problematic thoughts and attitudes revealed by the food diary. It involved providing factual information on topics such as the physical consequences of bulimia, the ineffectiveness of vomiting and using laxatives to control weight, and the adverse effects of dieting. The main point stressed by the therapist was that dieting encouraged overeating. For example, bulimic patients often embark on strict and rigid diets that are impossible to maintain. As a result, at some stage they break their diet. This increases negative thoughts about their poor self-control. The aim of this stage is for the patient to reach their own conclusion that dieting does not work. In stage 3, the focus was on maintaining the new thought processes. For example, the patient would be asked to prepare a written plan for dealing with future times when they sense that eating is becoming a problem. Result. The findings indicated that patients benefited from this type of treatment in the short term, although long-term follow-up has not been undertaken. Conclusion. Cognitive restructuring techniques can be used successfully to treat patients with bulimia nervosa. Evaluative comment. Cognitive treatments for bulimia have been successful in the short term. When combined with behavioral techniques, Whittle et al. 1999 found that patients fared better with cognitive behavioral therapy than any drug treatments available. However, more long-term research is needed to see if the improvements are permanent. In anorexia, the approach has yet to be significantly evaluated. One difficulty with the cognitive approach is that the individual may be using the eating disorder to experience some sense of control. Mnuchin et al. 1975 believed that enmeshed families, who were very controlling, contributed to the onset of the disorder. The cognitive approach involves a direct challenge of the patient's thought processes, which may be interpreted by the patient as further interference and control. Additionally, the cognitive approach focuses on the individual sufferer and ignores their social environment. Effectiveness of treatments. Around 70% of people with eating disorders eventually get better. Davison and Neal, 2001. However, recovery may take between 6 and 7 years, with frequent relapses. For anorexics, failure to maintain a healthy body weight can have a serious impact on the sufferer's physical health. Where menstrual abnormalities are present over a period of time, there may be permanent infertility. Anorexia can be a life-threatening illness, and death rates are twice as high for anorexia as for any other psychological disorder. Weight restoration can therefore be seen as a highly effective treatment for anorexia because it halts the physical consequences of acute starvation. However, other more psychological treatments such as cognitive behavioral therapy may be needed to ensure that the weight gain is maintained. Researchers like Mnuchin et al. 1975, as we have seen, argue that anorexia is not an individual problem but the result of interpersonal problems within a family. He recommended that treatment included the whole family and not just the anorexic. Fairburn and Cooper, in Horton et al. 1989, outline an effective cognitive behavioral treatment but also stress the importance of family involvement. In particular, family members must be advised of the patient's goals, and be included in strategies to strengthen the patient's motivation. Bulimia is often more difficult to detect than anorexia because the sufferer usually maintains a near normal body weight. Binging and purging tend to occur in secret. Treatment for bulimia may therefore be delayed, causing the symptoms to get worse over a long period of time. Rowan, 2002, found that a common time for bulimic women to seek help is when they are planning to start a family and are concerned about the possible effects on having a baby. Whilst there has been some success with antidepressants as a treatment for bulimia, few patients make a complete recovery, and disturbed attitudes to shape and weight tend to persist. A combination of cognitive and behavioral therapy has been effective in challenging these faulty perceptions. However, further research is needed to establish if the improvement is maintained over time.